host in this studio. Professor Ivan Bormat, sitting next to me, specialized in hepatogastroenterology at the Clinique Universitaire Saint-Luc in Brussels. And on the other side of the table, last but absolutely not least, Professor Jean-Luc van Latem, Head of Clinic in Digestive Oncology within the Department of Gastroenterology at the Erasmus Hospital in Brussels. All speakers here this evening are members of the board of the BGDO. Welcome, gentlemen and lady. Mark Peters, I'm turning to you as chairman here today. What should the audience expect? Why are we here?
First of all, I want to thank the audience to be present with us, because this is the first time that the BGDO is in a virtual setting and not in a live setting. We have experts around the table, and based on the new results that were presented at the World GI meeting, I think we will see interesting data, not only innovation, but also practice-changing data. And this is important for the clinician working day by day with patients and to make decisions what is the best strategy in a given setting. GI oncology is a broad spectrum, and that's the reason why I have a table full of experts. And I think all these experts will give ideas how to treat these patients, not only in the setting where they have local disease, but also at the moment that the patient have more advanced disease. So, like you said, it's important to have this data, but it's much more important to have and to receive questions, to have the question and answer session very lively tonight.
Okay, thank you so much for this short introduction. A short word to my technical friends. I still have talk back in my ear. Thank you so much. And we're turning to our first speaker, Professor Karen Geboes. You're going to bring us up to date on the latest finds on upper gastrointestinal tumors during the next 15 minutes. So the floor is all yours. Go ahead.
Thank you, Lies, and welcome to everybody. Voilà, let's start. I'm happy to be here and to be able to present the highlights of the last Barcelona meeting on upper GI cancers. It was a bit different to prepare slides for today because the meeting has only been attended virtually, and I do miss personally the buzz, the way that you talk about results when you see each other live. So I'm very happy to have this kind of virtual meetings. I don't think we have to travel the whole time as much as we did. But I miss them a bit, and I hope our rooms are not changing in this kind of rooms all over the world, because, that would be a pity. So the outline for my talk is the following. I will talk about metastatic tumors, mainly metastatic gastric cancer. And then in the second part about perioperative treatments, I will talk first on immunotherapy and then on molecular targets where possible. And I will always first tell you what we know now and try to integrate what is new from Barcelona into the knowledge that we had up until now. So for that reason, I first present the data from the Attraction 2 trial, which is an older trial, presenting results from nivolumab in patients that were treated in third line or further. And there we see that nivolumab, there's also data on pembrolizumab, showing that there's a benefit if you give immunotherapy. We have a second line trial, the Keynote 61 trial, comparing paclitaxel and pembrolizumab. And we don't have pointers, apparently, to show you something specifically, but as we see usually in treatments with immunotherapy, you first see some patients that do less good on immunotherapy, and then you have the crossing of the curve, resulting in a trial that does not show a benefit for immunotherapy. So that's second line, and I'll come back to this trial later. In first line, you have the Keynote 62 trial. That's the very difficult trial. It'll take me more than 50 minutes to explain. Difficult statistical analysis. It's in predefined patients with a CPS score of more than 1. So here it's a bit of selection. But I invite you all to read the full paper that has been recently published in JAMA and to try and understand the statistical analysis. But mainly it's a trial that does not show benefit clearly for immunotherapy. So we still need to know a bit better in gastric cancer for which patients to use immunotherapy and when do we have to use it exactly. And now it's going to be a bit difficult because it's smaller for me to see. So one of the trials that was presented in Barcelona is the DELIVER trial, and that's an observational study on nivolumab in gastric cancer. So it's not a randomized control trial. There's almost 500 patients in this study. And as you can see on the bottom of the slide, most of them are treated in third line or beyond. It's about, here we go, 60% of patients, and most of them have ECOG performance status 0 to 1, about 80% of patients. Half of them had ascites. What are the results of this trial? And the results are compared to the ATTRACTION trial. So we have a follow-up of 5.6 months up until now. So not such a long follow-up. You have a response rate that is about 7%, so that's low. That's what we usually see with immunotherapy. And a disease control rate that is similar to the ATTRACTION-2 trial. Do remember that the DELIVER is observational in a lot of third-line patients, but also second and first-line patients. And we have median overall survival data showing a median of 5.9 months, which is comparable to what was seen in the ATTRACTION trial. So what is interesting in this trial, well, the patients were also evaluated according to new methods of measurement. For instance, the tumor growth rate, which is something that people treating patients with neuroendocrine tumors will know. You compare the growth rate, so the curve before introduction of therapy with the curve after introduction of therapy, and see whether you work on the tumor growth in that way. So it's not only RECIST evaluation. And that is something that is interesting when we consider a thing that is called hyperprogressive disease. Now, this is a paradoxal accelerated tumor progression after the initiation of therapy, so immunotherapy, for instance. And it's something that is seen in other tumors that are treated with immunotherapy as well. For instance, lung cancer patients at an incidence of 8 to 21%. It's not the pseudoprogression that we usually see. The question is whether it's a true phenomenon that is induced by immunotherapy or whether it's something that is caused by a tumor that is already growing in a certain, at a certain rate, so due to the tumor itself. And there's a lack of consensus for the definition. So you see underneath some of the definitions that are taken for this, so different tumor growth definitions. What is TGR definitions? What is interesting in this trial is that we have 219 patients that have enough measurements to evaluate whether we see this kind of phenomenon in gastric cancer, and about 20% of the patients in this trial appear to have hyperprogressive disease. In the DELIVER trial, there's a very big translational part. So patients get stool samples and blood samples before the introduction of therapy and during therapy. And this might help us to get better biomarkers for hyperprogressive disease, because there are some suggestions that there may be genetic markers for this kind of evolution or clinical markers, and biomarkers for response. So in the future, this trial may help us to find answers. A second trial I want to show is the KEYNOTE-61 trial, which is a second-line trial that I've shown you before. And people looked into response to therapy after immunotherapy or chemotherapy. And that is, for instance, on the basis of smaller trials that have been presented at ASCO. There you have a retrospective analysis for the Mayo Clinic showing that in a set of patients that were treated with chemotherapy after immunotherapy, there was a better survival than in patients that did not have immunotherapy before. So the KEYNOTE is a very good trial to look into that. You have patients on paclitaxel in second line and immunotherapy in second line, and you can compare the ones that had chemo after that for survival. So it's not something that was pre-planned. Now, what do we see? We know that there's 93 patients that had chemo after immunotherapy and 117 that had chemo after chemo. And you see that the curves separate. So as I said, it's not something that was pre-planned, but it's an hypothesis-generating finding, still in small groups of patients, but about 100 patients in every arm. Then we go to the molecular targets. So gastric cancer is very interesting if you want to talk about targeted therapy. We have a lot of possible targets in there, but gastric cancer is also a very heterogeneous disease. So it's often a combination of molecular targets that induce the growth in the disease. And we've been working on that for a long time now. We have anti-VEGF treatments. We tried anti-VEGF treatments in gastric cancer. For instance, ramucirumab has shown some benefit in second line. We've tried anti-EGFR, we've tried MET inhibitors, and we know that trastuzumab is worthwhile in HER2 amplified tumors in gastric cancer in first line. But we have negative results with other HER2 blockers and in further lines. Now, there's a new agent out there that's called trastuzumab deruxtecan. It's a combination of a HER2 blocker with a topoisomerase, if I want to explain it very quickly. So that is a molecule that works a bit like irinotecan works. And this one has been investigated in a randomized controlled trial that's called the Destiny trial. So it's patients that are treated in second line and beyond. And they were randomized either to chemotherapy or this new HER2 blocker. And as you can see, we have very nice waterfall plots. We have response rates of 50%, which is very, very nice in second line and beyond. And we have nicely separating curves for survival, PFS, as well as OS. And we already have a paper here, so you can read a New England Journal of Medicine paper on this specific agent. Yes, OS is very good, 12 months. Problem with this drug is that it's once again a drug that can cause problems in the lungs. So also in other tumors, we see a higher percentage of ILDL, so pneumonitis, interstitial lung disease. So what do we know about immunotherapy in metastatic gastric cancer? We have an observational study that seems to confirm results that have been seen in later line studies. We have hypothesis-generating findings about chemotherapy after immunotherapy. That's a bit strange there. And we can look with the Destiny trial, or we hope to find in the Destiny trial, for instance, biomarkers for hyperprogressive disease and response. Up until now, we're only sure that MSI-high tumors are real candidates for immunotherapy. We can use the CPS score, so not the single score for PD-L1 expression, and there's some music in TM, tumor mutational burden, and EBV. For the molecular targets, in later lines, we have a very good trial with trastuzumab deruxtecan in the HER2 positive tumors, and there's other trials ongoing, so we're still looking for other molecular agents like claudin 18.2, tight junction proteins, blockers are under investigation, FGFR inhibitors and PARP inhibitors, and there are some nice papers already on combination therapy of immunotherapy and targeted agents as well. Now let's go to perioperative treatment. Where are we now? We usually use radiochemotherapy in esophageal cancers, adenocarcinomas, cross regimen, and we use FLOT in gastric cancer in perioperative treatment. One of the trials that was presented at Barcelona was the RTOG 1010 trial in, again, HER2 positive tumors, comparing radiochemotherapy according to Cross with radiotherapy of 50.4 gray and paclitaxel and carboplatinum with radiochemotherapy and trastuzumab. And this was a negative trial. You see that the curves completely overlap. Now, as a comparison, the adenocarcinomas in Cross, the radiochemotherapy plus surgery arm, had a median overall survival of 43 months. And here you have in the same arm like 38.9 months, so that's a bit less, but more or less similar. We have 80% surgical rate in both groups, and we have the similar PCR rates in both groups. So, and both arms have about 100 patients. So that's a negative trial. And this is not Barcelona, but it should be presented if we talk about RTOG. The Petrarca trial was presented at ASCO, and that's again in HER2-positive tumors, comparing FLOT plus trastuzumab plus pertuzumab with FLOT. This is a trial, that's one of the reasons why I presented where we are now. This is a trial that was stopped early because of the results of the Jacob trial. So we had a trial in metastatic gastric cancer showing no benefit of dual HER2 blockage. So all trials looking at that, almost all trials looking at that, were ended prematurely. So you have a lower number than that was foreseen. So not the statistical strength that you needed, but here you see that the curves separate, and we see a very nice PCR rate. Somebody is doing something with my slides. A very nice PCR rate of 35% in the patients that were treated with trastuzumab, pertuzumab plus FLOT. We still have a European trial ongoing, the EORTC, so I'm happy that that one was not stopped, where you have a control arm chemo, an interventional arm with trastuzumab, and then dual blockage. So this may be interesting results to follow up. So in perioperative treatment, and that is my last slide, we have some data in HER2-positive tumors, the RTOG 1010 trial, which is a negative trial. It may be underpowered. In the USA, they are discussing the backbone. So we usually use cross, like without any discussion, but they had a CALGB trial comparing carbopaclitaxel and oxaliplatin-based chemotherapy, and they have some reasons to suggest that that may be a better backbone. And there's also some old data suggesting that HER2-positive tumors are negatively influenced by radiotherapy, so there's discussion ongoing there. Petrarca is a positive trial that was stopped early because of a low number of patients, but there's similar trials ongoing. I did not find new data on immunotherapy in perioperative treatment, but I know that there will be some presentations at next ESMO. Thank you. That'll be all for upper GI cancers, and thank you.
Thank you so much, Professor Geboes. I'm going back to the audience, and I would like to invite you to send us your questions. Don't wait until the end of every presentation, because we have received no questions as yet. So do let us know whether you are there, whether you have something to ask our panel members. But I don't worry, because I have a great chairman next to me, and I'm pretty sure that I saw you writing things down, so I'm pretty sure that you have some remarks, some questions. So go ahead, Professor Peters.
So we first start with a general question. If you are facing a patient with a diagnosis of metastatic cancer, which type of biomarker will you perform in routine, knowing that there is a possibility of immune therapy, there is a possibility of trastuzumab? What is your policy?
Now, today.
Today,
I think my gastric cancer patients are, like everybody's gastric cancer patients, I hope, are, we always look at HER2 status. I think that's routine. Everybody should do it. And I also look for MSI. We usually do MSI on immunohistochemistry still. And then, we look further. If the problem still remains, I think you do it because you want to guide these patients to trials. You don't have access to immunotherapy immediately, but you do have to think about adding trastuzumab to your patients right from the front.
Other opinions? Everybody agrees?
I think that are indeed the two markers that have, at the moment, most practical implications in first-line gastric cancer. Checkpoint inhibitors, another marker for checkpoint inhibitors may be PDL positive. Although not done routinely in Belgium, but in the US, pembrolizumab is approved for PDL positive, strongly positive, second and third line. And if you look at the trial that you presented, that was published this week, actually the Keynote 62 Also, if you look there, regardless of MSI, the MSI high patients, of course, had more benefit. But the patients with a strong PDL positive tumor and strong as defined by CPS score of more than 10, they tended, I know it's a subgroup, it was not the primary endpoint, they tended to have more benefit. And that was true in the first line, in the Keynote 62, but it's also true in the second line, and also true in the third line trial and the Keynote 59, and that was the basis of the approval of pembrolizumab in the US, not yet in Europe.
Yeah, it's the reason why I put MSI high and CPS score as markers.
So there are some questions. One of the questions is, what is the actual situation for tumors of the junction? Do we use FLOT or CROSS?
Yeah, that's always the same question.
But we need to answer.
I know. But Willem Liebert asked something that's in the... Can I quickly...
Yes.
Because there was a question about PDL1, and it's true, PDL1 score, but you really have to know that it's a combined positivity score in gastric cancer. It's not a PDL1 score that you can use for lung cancer. That's always something important to say, according to me. And in track fusion, it's not something that I look for immediately. It's for patients that are... I look for it a bit later in not the first line metastatic patients right away. I don't think there's an answer for the junction tumors, FLOT or CROSS. I think there's specifically stated Sievert 3. So Sievert 3 are the ones that are considered to be gastric cancers usually. So you usually go to FLOT in this one, but maybe the question is junction tumors overall, and the higher junction tumors can be considered for CROSS. I can go into details there. We usually tend to think that, like in my center, we go easily to FLOT if we think that the tumor has more metastatic potential. So the higher node loads and the lower the tumor, the more we go for FLOT. We tend to keep, the way.
Jean-Luc, what is your opinion?
Yes, I agree. I think it's, of course, a difficult choice because we don't have data in the junction tumor, so we have to rely, I think, to the localization, Sievert 1, 2, 3. I think it's in this situation it could be useful to delineate the tumor. Although some tumors are Sievert 1, 2, 3, so it's a big, large tumor, and as Karen told us, I think that the metastatic spreading or the huge tumor are probably more treated by FLOT. And another point of discussion, more and more seen in our MOCCOM, is what to do if a patient receives CROSS operation but no answer, no response. Could we give you some adjuvant chemo like FLOT or FOLFOX? I think it's a big question and no answer.
Mm-hmm.
That's also a case-by-case discussion.
No real answer in this setting, but there was a meta-analysis published in JAMA Oncology last year looking at that questions, where it was shown that maybe it's a meta-analysis from different trials that there may be a benefit in this setting for chemo. The benefit was not large, but in the meta-analysis the benefit was significant in this setting, in this group of patients. And the second thing is, without disclosing the data, but soon at the next ESMO, it will be interesting to look at the presentation at the presidential session that may change our clinical practice.
Sure, because we need more than meta-analysis, because gastric cancer, it's like that. We rely on meta-analysis or Korean study, which
but
is not
there will be a
report.
There will be a report, and we are talking on checkpoint inhibitors of a study of patients being treated as well adenocarcinomas as squamous cell. It was as well esophagus as junction tumors with CROSS followed by surgery, and then there was a post-operative randomization between placebo and nivolumab for 1 year.
Yeah,
and the results will be presented at the next ESMO meeting.
Okay.
Yes.
I have two other small questions. One of a pathologist. We already discussed HER2 and MSI. What about EBV status?
Yeah, again, I'm a believer of benefit. But that's in the word. I'm a believer of the use of immunotherapy in tumors that, in EBV tumors in gastric cancer, like other inflammation-induced tumors in other organs. But again, it's difficult to find the checkpoint inhibitors. So I like to know it. If I know that there's a solid tumor trial ongoing where I can put my patient in, it's more, I don't want to give hope to patients that I cannot fulfill. So it's more like that I want to know whether the patient has EBV positivity, for instance. And that's a very specific
And then
question.
a final question, it's a clinical case. If your patient is treated with FLOT and resection, and after 8 months there is recurrence of disease, what is your treatment suggestion?
So the patient had FLOT after the surgery, and 8 months after FLOT, I suggest he relapses. So I think the later the relapse, the more you think the chemotherapy has worked and you reintroduce, and the sooner the relapse, you will go to second-line therapy.
What is late and soon?
Yeah, I know, that's the question. The question.
In clinical studies, that's 6 months. In
Yeah.
clinical
Yeah,
practice, that may be a bit more than 6 months, but in the studies, it's 6 months.
Yeah,
Here
so
it's
that's
in
what
between, 8 months.
Yeah,
That's
I
why
know,
the
it's
question
tricky.
was addressed like that.
It's extremely tricky. So, like, as Professor van Kutsum says, you can follow what the trial states. For me, it's an early relapse. So I would easily go to second line. I would be afraid to reintroduce the same chemotherapy here.
And which second line again? After FLOT? After 8 months?
Folfiri or Ramono or,
Okay. Let's wrap this Q&A up here. Thank you so much for your talk and for these very clear answers, Professor Geboes. Now, organizing a webinar or a congress like this, ladies and gentlemen, whether it's live or online, you know it requires a number of commercial partners. Now, let's look at and listen to some of their news for a couple of minutes. In that time, we can fill our glasses of water, and we will be back with you in a couple of minutes.
Hello everyone, my name is Valérie van der Linden. I am medical advisor at Servier in oncology. And today I have the great honor and the pleasure to interview Professor Karen Geboes on the management of metastatic gastric cancer. Professor Karen Geboes is head of clinic at the Department of Gastroenterology of UZ Ghent and professor at the Ghent University. Professor Geboes, can you remind us the current ESMO recommendation for the treatment of metastatic gastric cancer beyond second line?
ESMO recommends the use of Lonsurf in monotherapy for the treatment of adult patients with metastatic gastric cancer, including patients with GE junction tumors. And that is patients who have been previously treated with at least 2 prior systemic treatments for advanced disease. The recommendation is based on the results of the TAX trial. It's an international randomized double-blind placebo-controlled trial in 507 patients. We will discuss the setup of the trial and the main results in the following slides. We had some retrospective studies before and some series suggesting a benefit for chemotherapies as third-line therapy in these kind of patients, but the TAX study is the first one that is a really well-designed prospective trial showing strong evidence and a clear benefit for our patients, and as such, Lonsurf is the only recommended treatment supported by ESMO. Now, the question is whether we use third-line therapy quite often in gastric cancer patients, and we don't have real figures about the use in Belgium, for instance. We have some data from the US, UK, and Italy suggesting that about 40% of patients are treated with second-line therapy and about 20% of patients receive third-line therapy, but it is depending from center to center and country to country.
This recommendation comes from the TAX trial results. What are these results adding to your clinical practice?
Well, Valerie, in this slide, you see the setup of the trial. You see that 507 patients with an ECOG score of 0 or 1 were randomized in a 2-to-1 fashion to receive either Lonsurf at a dose of 35 milligrams per square meter orally, twice daily, so in the morning and in the evening, on days 1 to 5, and then again on days 8 to 12, of each 28 cycle, and then the other patients were treated with placebo. All these patients, as has been said before, had been previously treated with at least 2 prior lines of chemotherapy, so including a fluoropyrimidine, a platinum, and either a taxane or irinotecan. And if appropriate, they had received HER2-targeted therapy as well. The patients were treated until disease progression or until unacceptable toxicity. So median overall survival in third line was 5.7 months for patients receiving Lonsurf and 3.6 months for patients receiving placebo, with a statistically significant hazard ratio of 0.69. Progression-free survival was also longer in patients randomized to the Lonsurf arm, with a hazard ratio of 0.56. As you can see in this slide, and that's extremely important, quality of life was maintained while patients were on treatment, suggesting that the treatment was well tolerated with not many side effects. The most common adverse reactions are laboratory abnormalities in patients treated with Lonsurf, occurring at a higher rate than in patients receiving placebo, were neutropenia, anemia, a little bit of thrombocytopenia, and then nausea, decreased appetite, vomiting, and some fatigue and diarrhea. This is not different from what is seen when Lonsurf is used in other diseases. Treatment benefits were maintained across pre-specified subgroups. A multivariate analysis showed that some factors were prognostic for a better survival, such as, for instance, younger age or a lower number of metastatic sites. But after adjusting for these factors, the treatment effect of Lonsurf was maintained. Please remember that the TEX trial did not only include gastric cancer patients, but also patients with a tumor of the GE junction. And these patients also benefited from the treatment. So we already knew that Lonsurf is an effective and easy to manage treatment in later lines in metastatic colorectal cancer. And similar efficacy results are seen in this TEX trial in gastric cancer, which is a more aggressive disease compared with metastatic colorectal cancer.
Does this efficacy observed in the large phase 3 trial translate in your daily clinical practice?
Yes, we have started to use Lonsurf in our metastatic gastric cancer patients.
Thank you very much, Professor Geboes.
Thank you for the invitation, Valerie.
Welcome back, everyone. We continue this e-meeting with our second speaker this evening. That is Professor Erik van Cutsem, and we're still in the good hands of our chairman, Professor Mark Peters. Now remember, ladies and gentlemen, to follow the presentations together with the slides by making use of the arrows in the screen if you want to obtain accreditation points. Professor Erik van Cutsem, you will be talking about the current situation on colorectal tumors, right? So please, go ahead. It's all yours.
Thank you very much, Lies. And thank you also for all the audience. And happy to share with you some of the data that were presented as new data or discussed at the ESMO GI meeting. You may also be interested to know that this year, despite you were not there, that we had 3,770 attendees. So this was really a record year in Barcelona for attendees, all virtual. I hope that everybody can be back next year, but let's see how the evolution is. What I will do is take you through 4 topics in this talk. Molecular selection for metastatic patients, some data on cardiotoxicity of 5FU, on the prognosis in early colon cancer, and on locally advanced rectal cancer and the strategy. In regarding biomarkers, the first important study that was further discussed with a lot of discussion on this in Barcelona, first presentation was at ASCO, was Keynote 177 in the first-line treatment of patients with metastatic colorectal cancer, all patients with a microsatellite unstable tumor, and more than 300 patients were randomized between a standard chemo doublet, FOLFOX, FOLFIRI, plus bevacizumab or cetuximab, versus pembrolizumab. The primary endpoints of the study were progression-free survival and overall survival. Data on overall survival are not yet available, but we had a presentation on the progression-free survival, which was clearly better for patients treated in the first line with pembrolizumab versus chemotherapy. Survival may be a different story because we don't know yet, because crossover was allowed in this setting. And looking at the data, also interesting, and that's important also for the clinical practice for the future, is that if you see the curve, the green line with pembrolizumab, in the beginning there were 20-25% of patients who had a faster progression on pembrolizumab compared to chemotherapy, while in general the study was clearly positive in MSI-high patients. So we have to learn who are these patients, to understand who are these patients, and to develop new combination strategies or whatever for these patients, this so-called early progressors. Also looking at some other data of this study is the response rate with pembrolizumab. You can see the waterfall plots clearly better than with chemotherapy, and also the response rate 44% versus 33%. Another subgroup in colorectal cancer is the BRAF V600E mutant patients. You know that around 8 to 12% of patients have a BRAF V600E mutation. This carries a poor prognosis, and these patients are also quite resistant to chemotherapy. And what we have done is presented some updated data and also some new data on the relevance of tumor markers such as CEA based on the Beacon study. The Beacon study, which was a large phase 3 study in this patient population in second and third line of patients with a BRAF V600E mutation resistant to chemotherapy, we randomized these patients between control, and control was irinotecan-based chemotherapy plus cetuximab, versus a doublet, a BRAF inhibitor plus cetuximab, and the BRAF inhibitor was encorafenib, versus a triplet, so encorafenib, cetuximab, plus the MEK inhibitor binimetinib. And the updated data that have been presented at ASCO and ESMO GI showed that the doublet was as good as a triplet, but was less toxic. So that's why EMA recently, a few weeks ago, has approved encorafenib plus cetuximab in second and third line for patients with a BRAF V600E mutation, because as you can see, this median survival was almost double as long with this doublet compared to the previous control of irinotecan-based chemotherapy plus cetuximab in this setting. The question is, of course, is this only valid for second and third line, or also for first line? We don't have yet data from first line. We presented of randomized studies. We presented for the first time data from a non-randomized study in first line. This was with the triplet, BRAF MEK inhibitor plus cetuximab, and that's called the ANCHOR study. And we presented the first 40 patients of this study, and there was a response rate of 50%. So the combination works also with these new targeted agents in first line. We are now starting up a randomized study in first line with chemo versus this doublet, encorafenib, cetuximab, versus chemo plus cetuximab and encorafenib, to see whether we should treat these patients first with chemo or immediately with targeted treatments, or with a combination of targeted treatments plus chemo in this situation. Karen has shown you already this drug, trastuzumab deruxtecan, antibody drug conjugate with high activity in gastric cancer. We have seen some data also in colon cancer, HER2 expressing positive colorectal cancers. You may know that this is only, or most often in left-sided RAS wild-type tumors. in a relatively small non-randomized study, it was seen that and reported that there were 45% of patients having an objective response with trastuzumab deruxtecan. So in the further personalization, individualization of patients, that's becoming also an important direction, and that's why we look today at all patients, especially left-sided and RAS wild-type tumors, at HER2 expression, because there are new treatment options for these patients. Another topic, maybe a little bit less sexy, but is a study from the Finnish group, Pia Österlind, on reporting on patients with fluoropyrimidine-related cardiotoxicity. Almost everybody, or maybe everybody of us, has seen some patients, even young patients with coronary spasms. And Pia Österlind presented data on 137 patients, multi-center, who had cardiotoxicity after different fluoropyrimidines, 5-FU or capecitabine, who were then later treated with S1, which is a combination of Tegafur, a prodrug of 5-FU, a DPD inhibitor, and then otracil also. And they looked at these patients, and you can see that only 4 of these patients had previous cardiotoxicity to 5-FU or capecitabine had cardiotoxicity to S1. The explanation is that the metabolism, some of the metabolisms that causes this cardiospasm are not there with S1 or in less high amounts there with S1. And there is now discussion also at some levels to see whether this drug could be brought available for us in colorectal cancer, especially in this indication, based on these data, for instance. Looking also at some other data, and then we are going more towards early disease. You know that the ID trials in stage 3 and stage 2, looking at 6 months of oxaliplatin-based therapy versus 3 months, there were some interesting data presented also at ESMO GI in Barcelona of the Japanese cohort of these studies, looking at 3 versus 6 months CAPOX in this study, and looking especially also at the recurrence pattern of these patients and looking at the relevance of the T factor and the N factor. And what is clear from this large study also from Japan is that what everybody of us expects to see is that patients with a T4 tumor have more peritoneal metastasis than patients with positive lymph nodes. But what is even more important is that looking at the prognosis, the T factor contributes more than the N factor, and in this setting. And if we consider a 6 months treatment for the very high risk patients, the T factor still plays a more important role than the N factor. That's what they presented. And they said also that N factor is probably not a real driver to give an adjuvant treatment for 6 months. T factor is more a driver in this setting. So that were some of the data that were presented and discussed. And this is a slide of the discussant of Thierry André, but I summarized already some of this data. Jérôme Gallon from France presented also some interesting aspects on the newer further classification of colorectal cancer. We're looking at classically at the TNM, and he added the dimension of TNM-I. TNM immune classification, not completely validated based on the Immunoscore system that has some promises, and we hope to start in Belgium also with some trials on Immunoscore in the setting in the near future. But they looked at that further to build up on top of, not in place of the classic TNM classification, but then to make a new grouping, and I don't have time to go in details into this, but a TNM-I, as we call it, the TNM immune system in this setting. And Jérôme Gallon is always a defender, of course, of the Immunoscore for different reasons. He presented quite some enthusiastic, let's say, arguments in favor of Immunoscore in this setting, and it's true that it has probably some valid, although we have to find out where the exact place of the TNM score on top of the TNM score is. It's clearly a prognostic factor. It can distinguish poor and good prognostic patients. It's not really yet proven to be predictive, not to influence yet today the decision on adjuvant chemotherapy, but it may come. There is some further work ongoing, and in some countries, not in Europe, but in some countries, it's entering some of the guidelines. In Europe, it's not yet reimbursed, and it's not cheap the way it's done right now. And the final topic is also many of these data were already presented at ASCO, but there was a few weeks later at ESMO GI further discussion on 3 trials that were presented in rectal cancer to look at new strategies. The standard for these patients until recently was standard preoperative long course chemotherapy followed by TME in our country, but we know that many patients still develop metastasis. And there are different emerging strategies on more neoadjuvant chemotherapy before or after the radiotherapy or replacing the radiotherapy, and non-operative treatments such as the watch and wait strategies. And therefore, the different studies that were presented, and I will summarize the different studies in 1 or 2 minutes to end up, the different studies are going towards more intensification, a strategy of intensification with more chemotherapy, but also de-intensification, less surgery, less radiotherapy. So we can group them around these themes in this setting. The Dutch, or international, but led by the Dutch, Rapido study was a study of long-course chemoradiotherapy followed by surgery, followed by chemotherapy, versus the experimental arm, short course of radiotherapy, then chemotherapy, and did it quite long, 9 cycles of FOLFOX or 6 cycles of CAPOX, followed by TME surgery. And they've shown that there were more complete responses, pathologic complete responses with the experimental arm, with the so-called Rapido regimen. There were less recurrences in these patients. Overall survival was not yet different, but follow-up is relatively short. And here you can see the disease treatment-related the failure rates, which were favorable for patients in the experimental arm, lower in the experimental arm, with the Rapido regimen versus the classic long-course chemoradiotherapy. The French have worked on that theme also. So classic long-course chemoradiotherapy followed by surgery, followed by adjuvant chemotherapy, compared with 3 months of chemoradiotherapy and surgery, and then again chemo. And they have shown that adding more chemotherapy was better, was favorable for the patients. And the Americans finally have done the OPERA trial, which was a trial looking with long-course chemoradiotherapy before the operation, and then the chemo, extra chemo, either in the interval between chemoradiotherapy and the operation or before the chemoradiotherapy. And both strategies seem to improve the outcome. However, the strategy, and that's shown on the right curve, the strategy of starting with chemoradiotherapy and then chemo leads to a more TME-free strategy in this setting, so less operations, more watch and wait strategy in this setting. So these 3 studies, if we bring them together in a short discussion and a short conclusion, we can say that the treatments are changing. Watch and wait is an option for early cancers, especially. And in this setting, we may go for long-course chemoradiotherapy. But for the other tumors, it's probably more switching, and that's what we have adopted now in Leuven, a so-called modified Rapido regimen of short course radiotherapy followed by 6 cycles of FOLFOX followed by surgery. In order to have it a bit shorter, we think that 9 cycles of FOLFOX is a bit too long for these patients. And of course, I want to welcome you next year again with Michel de Creux as co-chairman now instead of Mario Di Cato next year at ESMO GI. Same dates in Barcelona, hopefully. Thank you very much.
Thank you so much, Professor van Cutsem. Let me compliment you also on your timing. Perfect timing. We have some very enthusiastic people in our audience who are sending us questions, so that's very nice. Don't forget that you can participate in these Q&A sessions. There's a button at the bottom of your screen that says Ask a Question. It's as simple as that, and then they will appear on our iPad. I'm turning towards my neighbor here, my chairman, Professor Mark Peters, would you like to start with the audience questions, or do you have remarks?
We can start with topics.
Go ahead.
So we will start with immune therapy. Everybody was waiting the first line data. My first question is this sufficient to convince the EMEA to go to registration of immune therapy in MSI-high?
Well, we have to
knowing that it's only PFS for the moment?
We have to ask it to EMA, but if I'm asked to defend or to be as an expert, which I do regularly at the EMA, I would say for sure, yes, it is enough. We have seen approvals with less convincing data. There will be never a survival benefit, I guess, because there was crossover, as I pointed out. We know even without crossover in other trials in colorectal cancer, because of second, third, and fourth line and so on, this even if there's a bigger difference, this survival difference goes away if there's a bigger difference of PFS in first line. So yes, and also it goes online. It's not the only trial in MSI colorectal cancer patients. It's the first randomized data set. We have many other data sets in later lines, and they all go in the direction of personalized medicine in this setting with a big difference. We're not talking of a trivial difference. It's a big difference. And I think if EMA would not approve that, I think it would be a mistake and a missed chance. And then we may become in Europe a third world region.
Yeah. Coming to a question related to immune therapy, we have seen impressive difference for PFS. Response is different, but rather low if you compare it with other regimens, not in this MSI population. But one of the questions is, don't we need to look for combinations with immune therapy, two different drugs, or, for example, combination with chemotherapy in frontline to increase the response and to increase the impact on the outcome of these patients?
Yeah, of course, that's what we have to do, and that's why I alluded to when I showed the slide of PFS, when we see that there are some early progressors. I mentioned that that's a group that we may have to go for combination, but of course we cannot yet fine-tune and discriminate and predict who are these patients. But in the preparation, I added an extra slide that I took out here that just answered that topic also. I took it out for the sake of timing. But we presented also a study that is now submitted for publication in the first line of, for instance, in the Nivo plus ipilimumab. It was non-randomized data sets. It's a small study, but the response rate was much higher, was more than 60% with 13% complete responses with Nivo plus ipilimumab. And there are some studies ongoing right now also in the first line, for instance, with FOLFOX, bevacizumab plus or minus atezolizumab. So this topic is being explored right now.
But isn't that a problem that you have a lot, with the exception of these data, a lot of single-arm, non-comparative trials not answering really the discussion that we have, because the delay of the registration is due to the fact that we don't have a good randomized trial?
That's correct. But in this group of patients in later lines, it was when we saw the data of Nivo and Pembro or Nivo plus EP in later lines, they were so convincing that it was in later lines almost impossible to compare that, for instance, with one of the other agents, regorafenib or trifluridine. It would be almost non-ethical to randomize that. And that was the challenge and the issue in this setting. There are, on the other hand, there was the design of this 177 study that was hoped to be presented 2 years ago, but because of the low number of events and the long follow-up that was needed, the results are only available right now. But it's true, we need randomized data, and they will come now in this setting. But I do think that now there is enough evidence to have these drugs already available for our patients.
Karim, you want to make a remark?
I just wanted to know, do we know anything about BRAF status in these tumors, for instance?
In this, I don't have yet some of the data on 177, but there are some other data published that if you give Nivo, for instance, I'm referring to one of the Checkmate studies, Checkmate 142, if you give Nivo to BRAF wild type and BRAF mutant, the activity is similar in this setting. That's a subgroup analysis, relatively small set of patients. And you know that there is an overlap between MSI-high and BRAF V600E.
I know, because that's going to be, if we get access to checkpoint inhibitors in first line than the MSI BRAF mutants?
My personal opinion is that if you would have access, then if a patient has both alterations, MSI and BRAF, I would go for a checkpoint inhibitor first and then go for a BRAF combination.
Mm-hmm.
I have a related question. We have seen small series, but also in the MSI high, you have a high frequency of anterior K fusions. Knowing that there you have responses of up to 70%, if this is confirmed, what will be your choice at that moment, having both drugs available?
There is no scientific answer to that question.
No, but I ask your experience.
My experience, there are not so many patients, and NTRK fusions is rare. It's
but in that population,
it's 0.5% of all colorectal cancer patients, but they are not only, but they're confined to the patients with an MSI high tumor. I would probably still start with a checkpoint inhibitor, and if the patient fails to that, with an NTRK inhibitor. And in the future, we can look at combinations, of course, in this setting, like there are many combinations ongoing with checkpoint inhibitors, and I mentioned ipilimumab, but there are combinations ongoing with chemo, there are combinations ongoing with bevacizumab or other angiogenesis inhibitors also in this setting.
Okay. Moving to rectal cancer, I have 3 questions on rectal cancer. One of the interpretation of Rapido is that there is a higher pathological complete response, there is impact on PFS, but we don't have overall survival data. And so you are making a statement, we changed our strategy based on Rapido. So it's a question coming from the audience.
I think I still believe that we can change our strategy on that. Survival will take very long, and if we will have to wait for survival, then we will not move forward in this setting. But there is also a risk that in this situation, the survival will not be clearly different. That maybe because if patients have metastasis, and that's the most frequent relapse, then you treat them and then the difference will become smaller. The difference with Rapido and classic chemoradiotherapy in disease-free survival was there, but was not. The curves were not completely separated. They were different, statistically significant. And if you look at the data, these data from this study, together with many other data, indirect data from other trials, the other indirect data are not enough. But combine these data, I do think that there is enough evidence that giving more chemotherapy in these patients and that switching to this strategy from the total neoadjuvant treatment and variations of this, that they offer a benefit to the patients. On top, it's not only the disease-free survival, it's also the fact that you see with this strategy more patients that you can do sphincter saving, or that you can keep the sphincter, and that you don't have to do a surgery. So go for a watch and wait organ sparing strategy in this group. You see that, and you will see it in some patients, and it's more frequent, and that's what reported in the different studies.
Then the last remark, is there a difference between the TNM stagings? Do we take all the from T2 to T4?
Well, I think that depends on the localization of the tumor. High up tumors, very high up tumors, there we may be a bit more conservative with adopting a strategy of neoadjuvant treatment. In the past, we irradiated every tumor with high tumors far away from the mesorectal fascia. We probably need less radiotherapy unless there are big lymph nodes, and then chemo alone may be also an option. So yes, the TNM plays a role in this setting.
Okay. Yeah, Jean-Luc? Final remark, 1 minute.
No, but I think that in rectal cancer we should be happy with this trial because it changed our practice, and we have to change. Maybe not to focus only on Rapido, but one question remains. In fact, there is still an open question, but the sequence of treatment, I like the French trial for probably bulky tumor, starting with chemo, FOLFIRINOX, which is clearly intensified treatment, and then moving to probably a short course of radiation therapy. So maybe the next trial could be a mix of both attitude to go for a very pragmatic standard.
So the discussion is still open.
Yeah.
But the practice is changing.
Yeah.
Yes, but probably due to the fact that we are integrating chemotherapy
Okay, thank you, gentlemen and lady, for your contributions here. Professor Ivan Borbat, we haven't heard you very much this evening,
No.
but you're up next for your next presentation. After we take a few minutes to sharpen our brains here to listen to the next presentation, we're going to take a small commercial break first.
Hallo, ik ben Vincent, Key Account Manager voor Pierre Fabre Oncology België.
Hello, je m'appelle Amélie Nguyen et je suis Key Account Manager pour Pierre Fabre Oncology et j'ai hâte de pouvoir vous rencontrer.
Hallo, ik ben Kimberly, Medical Science Liaison bij Pierre Fabre Oncologie België en Luxembourg.
Hello, je m'appelle Audrey et je suis Medical Scientific Liaison pour Pierre Fabre Oncologie Belux.
We at Pierre Fabre take care of life by designing and developing innovative solutions inspired by consumers and patients and contributing to the well-being of everyone, from health to beauty. We achieve this by cooperating with healthcare professionals, our trusted partners worldwide, and by drawing relentless inspiration from nature and plants, and by placing pharmaceutical ethics at the very heart of our operations. Pierre Fabre carries out unique synergies between our different brands, all sharing the same objective: caring for cancer and chronic diseases, preventing and caring for everyday ailments, and caring for the skin and the hair. The Pierre Fabre Group belongs to a public foundation as the majority shareholder with over 85% of the company's shares. The Pierre Fabre Foundation receives the dividends it needs to pursue its public interest mission to help those in need. The latter is focused on improving access to qualitative medication and healthcare in the least developed countries in Africa and Asia. In Lebanon, for example, the foundation is setting up mobile medical units to treat Syrian refugees in the camps. Additionally, faced with a high prevalence of skin diseases and the lack of trained personnel, the foundation is working to create access to diagnostic consultations and dermatological treatment. It is particularly involved in helping those with albinism, a highly vulnerable group that often suffers from skin cancers. Pierre Fabre Oncology, part of the Pierre Fabre Group, has experience in oncology since 1978 and provides therapeutic solutions for melanoma, lung cancer, breast cancer, stem cell transplantation. Most recently, the EMA approved the combination therapy of encorafenib and cetuximab for the treatment of adult patients with metastatic colorectal cancer with a BRAF V600E mutation who have received prior systemic therapy. Interested? Find more information on our treatments and products, educational videos from previous congresses, upcoming projects and our team on pierrefabreoncology.be. Do not hesitate to contact our medical team with your questions or if you want more information.
Welcome back, everyone. Moving to our next presenter. Don't forget to follow the presentation together with the slides by making use of the arrows in the screen. I keep repeating it, but it's the only way to obtain your accreditation points. And don't forget to join in our group discussion by sending us your questions. Now, Professor Ivan Borbat, the next 15 minutes are dedicated to hepatocellular tumors, and the floor is all yours. Go ahead.
Thank you very much. I want to present to you a very subjective selection of reports that were shown and discussed at the last ESMO GI meeting. As Karen, I pitied the fact that it was online because we lacked the interaction and the discussion, which are still more lively. Hopefully next year in Barcelona.
That's the plan.
Yeah. Okay, so HCC, as I will call it for the next minutes, is a very particular cancer because we deal actually with two diseases. Of course, the tumor and its factors, but also the liver itself. And that's why classifications are particular for liver cancer and take into account of course, the performance status of the patient, but differently from probably other cancers, the liver function plays a real important and a key role. And today, of course, because of the presentations and certainly for the sake of time, I will not address the early cancers where transplantation and surgery take the most of treatments, but most advanced disease. And this is the classification that probably much of you know, which is a Barcelona liver cancer group classification that depicts 5 different group of patients from 0 to D. I will today discuss patients with stage B for one trial and mainly stage C, which are patients with advanced disease, whether they are metastatic or with a vascular invasion. So this is highlighted here. So I would say HCC is a little bit of a parent pauvre, if I would say in French, of GI oncology, because it has been a long period without any systemic treatments, and it was long the case that local regional treatment, surgery, and very particularly transplantation played a role. And we have only for 10 years, 2008, the first drug that was approved, which is sorafenib, and then more recently some kind of explosion with many different compounds, and very lately, and I will discuss this in a trial, the combination of anti-angiogenic treatment and immune checkpoint inhibitors is now the new standard. So, in more details, the 4 presentations that I will show and discuss a bit with you. The Checkmate 459 was a negative trial that assessed the effect of nivolumab versus sorafenib in first line. That was shown at last year ESMO in Barcelona, but another meeting in Barcelona. And then the second oral presentation looked at a subpopulation of the IMbrave 150, the older patients that were treated with a combination of atezolizumab and bevacizumab. And then I selected 2, that's because of my interest, short oral presentation. One that was a pooled analysis of safety, efficacy of transarterial chemoembolization using particular drug-eluting microspheres, and then the second, which I find particularly important, also again a subgroup analysis of patients with decreased liver function receiving cabozantinib. So first, the Checkmate 459. To remember you the design of the trial, it's a very standard design in the field of HCC, looking specifically at patients with preserved liver function. That means Child-Pugh A,
good function patients, and they were like classically randomized either to the standard sorafenib or nivolumab. The primary endpoint was overall survival. There was a difference that was unfortunately statistically non-significant. And Bruno Sangro and colleagues presented their longer follow-up at the last ESMO GI meeting. So if you want to read the small numbers, let me highlight them for you, just to show you that the hazard ratio remained the same with longer follow-ups, but the curves tend to separate between the two groups. P-value came closer to signification at 0.052, but still the trial remains unfortunately negative. So the same discussion with the MSI patients probably, and the same discussion over and over to detect the patients that would eventually benefit from immune checkpoint inhibitors also in HCC, as certainly a proportion of patients really benefit. What was interesting also is to look at different subgroups of patients, those with HCV that are more often found in, I would say, the rest of the world compared to Asia, and the patients that have HBV generating tumors. Let me just highlight the fact that they are behaving poor, not that good. You see the median overall survival in this group, in the two groups, is lower, but still seem to be a benefit in subgroups. The fact is, much of these patients were treated after progression, and what I would like to see in the future is post-progression treatment, and to see the outcome of those patients post-progression. So my comments on this first trial would be that, we have high numbers in each group. We have 3 different sequences, like nivolumab followed by TKIs, sorafenib followed by TKIs, and sorafenib followed by immune checkpoint inhibitors. So would be interesting to see what becomes with those patients. Now, the second oral abstract that I wanted to show you is the subgroup analysis of old patients enrolled in IMbrave 150. Overall, you know that this trial was clearly and very impressively positive. We wait for such a trial for a long time in the field of HCC. The design here, actually, I could copy and paste the design of all phase 3 trials in HCC for like 10 years, because they always address the same patients. Child-Pugh patients and stratifications are really also quite the same over time, like Asia versus rest of the world, because of the different etiologies and the different prognostic factors between Asia and the rest of the world. Randomization was atezo plus bevacizumab compared to sorafenib, which was still the standard at the time. And we looked for a double endpoint, overall survival and PFS. Now the trial is positive, clearly positive. I don't have the curves to show you, but there was a real increase in terms of overall survival, although the follow-up is quite short, and PFS. Other very interesting points of this trial were the response rate that was increased and becomes really interesting in the field of HCC, and also quality of life, which was, and that is rare, but so needs to be mentioned. It was improved by the doublet chemotherapy, not chemo, immunotherapy and anti-angiogenic treatments. I'm sorry about the table, which shows very small figures, but there are some differences between older patients and the overall population. The big differences are less males in the older population, less HBV patients, and less advanced patients. Still, the patients above 65 benefit from treatment, as you see here in these survival curves, and as PFS and overall survival is improved in the subgroup. So the authors concluded that the treatment is efficient in this subgroup, and also the fact that the treatment is well tolerated. I have comments about that I can discuss, of course, with you afterwards. But I think that you could agree with me that fatigue, diarrhea, and decreased appetite are difficult to treat side effects in the day-to-day handling of patients, and that all these AAs were a little bit higher in the older populations. So my comments and conclusions, the treatment is efficient also in patients above 65, although they are a bit different than the overall population. They have less hepatitis B. They are much less in Asia, which is logical because HBV is very frequent in Asia. And they, to me, they experience a little bit more difficult to treat adverse event. Now, I did not plan to present this, so I will skip for the sake of time and directly go to this retrospective analysis presented by Thierry Debar, which is a interventional radiologist in the name of his colleague, among which I like to mention Gontran Verset, hepatologist in Erasmus, my friend, very active in HCC. So Dr. Debar and colleagues reported one of the, if not the largest, compilation of patients receiving chemoembolization. So chemoembolization is a local regional treatment aiming at injecting directly intrahepatically via the hepatic artery some drugs. In this case, they assessed the efficacy of live pearl beads, which are beads that are calibrated to a certain size and deliver fixed and, I would say, in a way, predictable dose of chemotherapy inside the liver. So they assessed this efficacy in various patients, and that's maybe one of the comments that we could give to the study, which was the fact that the population was heterogeneous, very early patients. So that means patients with stage 0 or A, which are really small tumors, probably maybe with the philosophy of advancing into a more curative treatment, which could be a transplantation, but also more advanced patients. They report very impressive results to me, with a 60% complete response after usually 2 sessions, and an overall control of the disease of nearly 90%. The other, I think, quite advantageous finding of this large-sized study, of course with the bias that it is retrospective, is the fact that the severe adverse events were quite rare, and especially hepatobiliary toxicities, which is the most feared toxicity, was only detected in less than 7% of patients. It's always difficult to assess PFS and maybe time to progression in a heterogeneous population. So these numbers are, for me, a bit difficult to analyze, but still I think that TTUP, which is time to untreatable progression, thank you, was close to 20 months, which is rather good to me. So comments, it is a retrospective trial, but it's a big size trial, and the 2 facts that it was a well-tolerated treatment and with an impressive disease control rate, I think is worth mentioning. And now finally, as a short oral, Dr. El Khoueri and colleagues from the US reported a subgroup analysis, which to me is quite important. which is the outcome of patients that were included in the Celestial trial. Celestial is the phase 3 that proved that cabozantinib is efficient in second and third line after progression under sorafenib treatment, usually. And what happens to these patients that do deteriorate their liver function during the study? So as all trials, these trials did not include patients with Child-Pugh B, but only patients with preserved Child-Pugh A function. But a proportion of them had their liver function that deteriorated over time. So after 8 weeks, about 10% of those patients were Child-Pugh B. And they report that in this patient population, the efficacy of cabozantinib was maintained, as you see here in this curve. The PFS was improved, and also no, that's the OS, sorry. The overall survival was improved in this group, and with a good hazard ratio. Of course, this is subgroup analysis. The other thing is that although liver function was deteriorated, the drug was well tolerated. And to make a long story short, you will not see a meaningful difference in the side effects that are reported here, which are the most important side effects of the compound. So Child-Pugh B patients are really the orphans of treatments in HCC. They don't deserve any compound. So we should look more into it with regards to tolerability and of course overall survival of certain drugs in this sometimes quite difficult to treat population. And with this I have finished, and I have a poll question, which is a bit of a funny one, which is, do you know where this hotel is?
HCC Hotel.
HCC Hotel.
Eric.
We stay at home.
Is it in Brussels?
No, in a place where you go quite often, Eric.
Barcelona.
Yes, of course, Barcelona. Thank you.
And that's where you want to go?
That's where I want to go.
Next year?
Next year.
But that would mean I would be out of job.
We can do both. We can do both.
You can take me with you.
We do a mixture of both.
Wonderful. Gentlemen, it's a deal. Thank you so much for your talk, Professor Borbat. And the audience is absolutely very active at this moment. We have quite a lot of questions. So I'm turning towards our chairman, who will do, again, a wonderful job of combining all these questions.
Okay, let's start with an easy one. So we have seen interesting data on immune therapy, and a practical question. If you see the data of IMBRAVE, they are amazing, the combination of Atezo and Beva. And it's a practical question of one of the persons in the audience. If you have a patient with a variceal bleeding, are you afraid to give bevacizumab in that patient?
So whoever that was, I thank him, because that's also a very important question to answer. It's everyday practice. Indeed, the most severe side effects observed in the IMBRAVE trial, and including deaths of patients, were happening in patients with that developed variceal bleeding during the trial. So it's really something that needs to be stressed. Now, you know that this combination is available through an MNP program, and I would really advise, no more than advise, stress all physicians to do gastroscopies to their patients and to assess the size of the varices and the at risk of bleeding varices, and to treat them eventually before to start. I think that's a really important point. Yeah.
Good point. Another question is on the population that were studied. You have the IMBRACE, which is positive. You have the checkmate with Nivo, which is trying to be positive, but still is negative. Is it a difference in population? Is there a difference, for example, might the difference be explained by subgroups, non-viral, viral, that is different in both studies?
I can't tell by heart the exact proportion of patients with a viral and non-viral disease. The fact is, I think the combination of immunotherapy with anti-angiogenic makes really a sense, and to me the trial is positive because it is a combination of immunotherapy.
Independent of the viral.
Yeah, I think so. Really, okay. Yeah. The checkmate was discussed, and people say still we have efficacy with monotherapy, with immunotherapy, and the fact the trial is negative is because the sorafenib arm was so doing so good. Actually, it's the best overall survival that is obtained with sorafenib over all the trials. It's close to 16 months, so that's really a lot. Probably that's one reason. I don't know why in this trial patients behaved so good with sorafenib, but no, I think really the fact that one trial is positive is because the combination is there.
Mm-hmm. I have a question to all the panelists. If we look to the curves in the checkmate, you don't see the drop in the beginning of the curve. The curves are together. Do we have an explanation why it's different in HCC than in most of the other tumor types, even outside GI?
Yeah, but you have a drop in both curves, both arms.
Yeah, but normally
the drop is not bigger with.
Yeah.
I think the reason is that because the control arm sorafenib is less powerful than the chemotherapy. That's probably the reason, and that's both groups go down the same amount.
Okay. Then another question is on the interventional radiology trial. Do we really need the chemotherapy component in TACE?
So I see that my friend Chris asked me this question. Well, if we rely on evidence, the evidence is poor, is favoring chemoembolization. I'm aware of only one trial that actually assessed embolization versus chemoembolization. It's a Spanish trial that is already like nearly 20 years old now, and that played an essential role in assessing TACE as a standard for BCLCB patients. Now, we should maybe, if a company would be willing to, we could randomize patients with these modern devices, which have really calibrated size with the same device with the chemotherapy. I think that's a really good question, but I'm not aware of any physician that is using bland embolization to treat HCC. It's different from metastasis, but to treat HCC, but we should maybe try. Yeah,
okay.
Good proposal.
And then a final question is lenvatinib. What is the position against Atezo and Beva?
I think we should mainly look at patients that cannot receive the combination therapy. That is to say, and there is still a proportion of patients that do recur after transplantation. Of course, this is a contraindication to immunotherapy. The second thing is, I think maybe, although we don't have evidence of the safety of lenvatinib in patients at high risk of bleeding, but yeah, the IMBRAVE is very convincing, so it's going to be difficult to take position besides this treatment.
Thank you so much, and thank you, ladies and gentlemen, for your very intelligent questions. Keep up the good work. There's still more to discuss. There's still more to listen to, because we have our last presentation coming up after some news from our commercial partners. So we'll see each other in a couple of minutes to listen to and look at Professor Jean-Luc van Laten.
Hello, my name is Nicolas Matuzak and I'm medical advisor for somatulin and Xermelo at Ipsen. At Ipsen, we strongly believe that convenience matters, and therefore we are going to talk today about the importance of the ease of administration of long-acting somatostatin analogs, or in short, SSAs. Long-acting SSAs are commonly used in the treatment of neuroendocrine tumors and acromegaly, both chronic conditions requiring long-term treatment. So it's important to optimize patients' treatment experience. There are different SSA brands available on the market, yet we see important differences in the ease of administration among these. In order to compare the administration characteristics between the current SSAs available on the market, the PRESTO study aimed at assessing the preferences of nurses between lanreotide autogel and octreotide LAR, or long-acting release. This international multi-center study, including 3 centers from Belgium, enrolled nurses having more than 2 years' experience injecting lanreotide autogel and/or octreotide LAR. Some key features of the newly designed lanreotide syringes are larger flanges, finger supports for pushing the plunger down, the new plunger supports, a larger ridged non-transparent needle cap, previously a see-through needle shield, and a new protective tray. With the preference study of lanreotide autogel, or PRESTO study, we introduced the first study to ask nurses experienced in injecting long-acting SSAs in patients with NET and/or acromegaly to report their preference between the lanreotide new syringe and the current octreotide syringe. The primary objective of the study was thus to assess the preference for the lanreotide new syringe compared with the octreotide syringe by asking the nurses to perform injections into injection pads with a single preference item ranging from slight to strong. In practice, nurses attended a single 60 to 90 minutes testing session. These sessions were standardized across testing centers and conducted in the local language. Each nurse tested 2 syringes of each product per injection pad in a randomized order and then completed the anonymous self-administered cross-sectional web-based questionnaire on a tablet device. Overall, 97.8% of nurses expressed a preference for the lanreotide new syringe, while 2.2% preferred the octreotide syringe, with a statistically significant difference, both in the first and the second analysis set. The secondary objective was to describe the nurse's preference, rating 9 predefined attributes. This completed graph shows the syringe attribute performance ratings. These performance ratings were consistently higher for the lanreotide autogel compared to the octreotide LAR syringe, with the greatest differences for fast administration from preparation to injection and confidence that the syringe will not be clogged. Finally, in this trial, nurses could also describe the importance of these attributes. The attribute most frequently ranked as most important was confidence that the syringe will not be clogged, followed by confidence that there's no loss of product during preparation and delivery. For both of these attributes, we see in that same graph important differences between both devices. In conclusion, the PRESTO study showed that nurses with either past or current experience injecting long-acting SSAs in patients with NET and/or acromegaly in the EU and the USA preferred the user experience of the lanreotide new syringe over that of the current octreotide syringe, when assessed through simulated injection. The attributes with the greatest difference in scores between syringes in favor of the lanreotide new syringe were fast administration, confidence the syringe will not be clogged. These results suggest that the lanreotide new syringe may therefore improve user experience compared with previous and/or current products when used in clinical practice. Since the injection experience plays an important role in the quality of life of the patient, a new observational study, the PRESTO 2, will assess this time the injection experience of patients treated with somatulene autogel and/or octreotide LAR. Thank you for your attention.
Welcome back, everyone. Let's move to our last speaker for this evening, which is Professor Jean-Luc van Latem. Professor, your topic is pancreatic and biliary cancers, so the floor is all yours. Go ahead.
So thank you and good evening to all our virtual attendees. I hope they are still connected because we are late.
I'm pretty sure they are.
But pancreatic and biliary cancer, I think it's of interest. And I'm happy to cover some highlight discussion and give you some take-home message in this setting. And let's start with pancreatic cancer. I choose to speak about one topic of perioperative therapy for borderline and high resectable tumor, which was presented at the ASCO, not the Barcelona, but I think it's important to highlight this, the emergence of such strategy. We have also a topic on local regional treatment for locally advanced tumor, other topics for new chemotherapy compound in the setting of pancreatic cancer, and last but not least, the difficult setting of precision and immunotherapy in metastatic pancreatic cancer. So just to highlight the emergence of more and more neoadjuvant or perioperative trial in borderline or high-risk pancreatic cancer, and the US group, the SWOG, has reported during the last ASCO an interesting randomized phase 2 study, not comparing but exploring the most common regimen used in pancreatic cancer, modified FOLFIRINOX and gem-nab-paclitaxel in before and after surgery, with a primary endpoint of 2 years overall survival. And disappointingly, because the target endpoint was not so ambitious, if we look to the recent data of survival coming from adjuvant trial, you can see that the primary endpoint was not met, and so a bit disappointing for difficult to understand reason, maybe that all patients were not fully covered by chemotherapy, or it compounds high-risk cancer. What look interesting here, it's that both regimens were active, and you can see that gemabraxane was at least as active and a bit more active in terms of complete or major pathological response for this series. And so you can see that A0 resection, which is of course the major aim of the surgery, is high in this series. The toxicity profile is also good. Another presentation highlighting the fact that we have to move probably more and more to neoadjuvant therapy come from the SPAC5. I will not go into details, but you can see that the most important message is that whatever you give before surgery, it seems that it do better than immediate upfront surgery for borderline resectable tumor. So, of course, adjuvant chemotherapy is proven efficacious. We have a strong phase 3 trial coming from France, and FOLFIRINOX is now the standard for fit patients. Gemcitabine plus or minus capecitabine is for the others, and we have seen that Abraxane plus gemcitabine was not proven for benefit in the adjuvant setting. But more and more, and also in the guidelines, notably in the US, neoadjuvant therapy is coming, it's clearly emerging, and need clear validation at good trials. Probably gem-nab-paclitaxel is similarly active to FOLFIRINOX, but we have to prove that in more deeply in more large study with good different toxicity profile, but you have seen that good pathological response. So we need clearly prospective trial, pre versus post versus perioperative. What do we have to do? to use, FOLFIRINOX versus gem/nab-paclitaxel, and the additional question of adding radiation therapy, focusing on stereotactic body radiation therapy is still open and also needs validation. So coming to the locally advanced pancreatic cancer, we know that the standard of care is chemotherapy in locally advanced cancer, but we also need probably more specific trial in this setting for validating, for instance, the use of triplet FOLFIRINOX or gemabraxane in this setting. We have only phase 2 data. But beside the systemic control of the disease by chemotherapy, more and more used were ablative therapy coming from radiation therapy, microwave therapy, HIFU, etc. And it was reported during the Barcelona meeting, feasibility study, a multi-center study focusing on unresectable locally advanced pancreatic cancer, were associated to initiate chemotherapy, intratumoral injection of P32 microparticles. And you can see here the design of the study. The device is OncoSeal. It's implanted by US, so through US control. You can see that the patient starts with one cycle of chemo, FOLFIRINOX or gem/nab-paclitaxel, then the implantation, and then they continue to chemotherapy. The endpoint of the study were safety and the disease control rate at 16 weeks. Briefly, the trial showed that the safety and the feasibility, that means the delivery of the new compound, is okay. You can see that there is no major effect related to the implantation of the OncoSeal product, and globally the sequence of treatment was well tolerated. What about the efficacy? We don't know, because there is a mix of systemic therapy and local therapy, and probably we need a clear randomization for these techniques added to chemotherapy. You can see that there is a lot of response, but we can observe, of course, this kind of response under chemotherapy. Some patients can be operated, but the definition of unresectable disease should be also clarified in the future for very good trial. And you can see also that the median overall survival was around 15 months, which is expected in locally advanced setting. So good, maybe a good technique, but that needs confirmation. What about new compound chemotherapy? We know from the Napoli first trial that liposomal irinotecan is now approved in metastatic pancreatic cancer in the second line after gem-based chemotherapy. And now this compound is moving to first line regimen, and they will report a phase 1-2 trial aiming to determine the good dosage of the different drugs, liposomal irinotecan, 5-FU, and oxaliplatin. The dose expansion was formed, and there is a second part of the study with 25 patients enrolled with determined dosage. And what we can observe now from this preliminary data in 32 patients is that the therapeutic index looks promising regarding the overall response rate, similar or close to what we observed with the gem/nab and with the initial FOLFIRINOX data. It's the same with PFS, OS, and you can see that the side effect was a bit decreased, probably because the dose of oxaliplatin is lesser, with 0% of neuropathy and also less fatigue. But preliminary results. So what to do with the what we call the Nalirifox. That's a bit complicated. So probably expecting similar, maybe not superior, but at least similar efficacy to what we know, to be confirmed, maybe lesser toxicity, but the data were limited to a good population of patients. We are awaiting two important studies. The first one is ongoing. It's the trial from the company, which is the Napoli 3 in frontline metastatic pancreatic cancer, comparing the regimen derived from the phase 1-2 versus gem-nab-paclitaxel. And the second one is a trial we designed by the BGDO with a very good job by Yvan and other board members. And the study will be run in the second line compared to the usual Naliri 5FU, and we will test the Nalirifox combination in second line. So moving to precision therapy in pancreatic cancer, you know that from the Apollo trial there is a specific attention to specific gene, not only for precision therapy but also for improved screening and detection of at-risk patients in a hereditary context. And there is a Greek group that report the prevalence and the prognostic role of inherited germline pathogenic variant in cancer predisposing gene, but in unselected patients with pancreatic cancer. And you can see that they report 4% of finding pathogenic variant in pancreatic cancer-associated gene, and 7.7% in homologous recombination repair genes, which are the most common gene derived from the BRCA family in this population. And you can also see that if there is a family of cancer, the prevalence is higher. What to do with this information? The first one is a prognostic role for this kind of mutation. Probably the answer is yes, although you have to be cautious because it's retrospective and not prospective data, but you can see at the left figure that prognosis is better for this kind of carriers of mutation. For the prediction of and for platinum sensitivity, it looks more difficult to demonstrate the association. In the Greek study, this is not the case with negative interaction between platinum exposure and the mutational profile. But in another paper published in 2020, they found a positive association with the exposure to platinum and the HRD status, as you can see in the curve in the left. But probably we need more and more prospective data, but in a limited population because the prevalence is not so high. Another important point, because this is probably and could change practice, is that in patients with mutated BRCA cancer, gem plus platinum is probably a standard of care. Probably it's not mandatory to add a PARP inhibitor in the first line because the response rate and the survival curve are very high, even without the PARP inhibitor. So use platinum-based combination in this kind of patient. And coming back to the Apollo trial and the olaparib story as maintenance therapy, there was a new presentation in the Barcelona meeting, but focusing in elderly patients, small group, but the key message is that the elderly patient derive the same benefit, there is the same activity in this patient, not increased toxicity, and even less dose reduction in these populations. So we can give and treat our elderly patient with olaparib. More difficult is probably what to do with anti-stroma and or immunotherapy in pancreatic cancer. You can see in the slide presented by by Ellen already during her lecture that again we were very disappointed with a very huge and very well designed phase 3 trial in pancreatic cancer with anti-stroma. With the PH20 in selected population with enriched immunohistochemistry tests, but the study were negative. So again, what to make pancreatic cancer immune responsive? I will give no any details because for sake of time, but we can prime the tumor with new compound. Unfortunately, you can see here that even in selected population with combination with checkpoint inhibitor and this new compound focusing on specific fibroblasts, there is very poor responder in a specific population. MSI in one case and inflamed pancreatic cancer. I will go very fast for biliary cancer. Sorry, we have 2 minutes. You can see here that the progress with systemic therapy in biliary tract cancer are modest based on the first and the second line therapy, GEM-CIS, then FOLFOX. What about irinotecan-based chemotherapy? There is an Indian presentation in gallbladder cancer, but without no real impact, increased toxicity with the capillary combination and a negative trial, although there is small answer. More interesting is to focus on molecular-driven therapy, which will overpass the anatomical presentation of the cancer. Probably FGFR2 is a very good target with promising result in phase 2 data coming from Yale in 2018. There are again presented data, and to be very short, they have shown, but it is in retrospective data, that using and targeting FGFR2 is better in later line than using chemotherapy in these patients. A short word about NTRK fusion targeted therapy. Very few patients. It's active, but very rare, and my colleague and the moles show that the prevalence of such fusion gene is very, very, very rare, less than 1% in BTC. Immunotherapy, I just will highlight that there is response. Of course, could depend on the MSI status, and this is an ASCO trial showing high response rate. But in biliary tract cancer, I think that everything is to be done with immunotherapy and with also the combination. Regorafenib, but also Cocorico for the BGDO, because it's an active drug in phase 2 we published, and probably it's shown similar data to FOLFOX. And the next step, and again, we have to congratulate Yvan to push a very huge study with French and UK to go with maintenance therapy, but based on molecular-driven profile. And you can see the list of the different gene that we can target in this cancer. So in conclusion, sorry for the time, but probably chemotherapy is the backbone. Irinotecan or Naliri, maybe it's interesting. Targeted therapy focusing on FGFR2 or other molecular-driven therapy should be explored. regorafenib also should be further evaluated. Enterocare very rare, and immunotherapy. You can see there is some trials ongoing in line 1 and in line 2 setting. Thank you.
Thank you, Professor Van Laten, for this overview. I'm going to turn towards the chairman. We have no questions so far from the audience, but I'm pretty sure you have some.
We still have 2 minutes. So
go ahead, take your time.
So, Jean-Luc, I was somewhat surprised of the high response rate of nab-paclitaxel. It was not a comparison with the combination of FOLFIRINOX. Can you have an explanation in that study?
The data I show come from the RESOLVE trial, so that means not the initial trial from the company. And so we can observe that the more we use and the more the trial are moving, the best are the benefit. But I agree that this can be variable. But we see that we also see that with gemcitabine from 10 years ago, the benefits are better.
Okay. You make a statement that neoadjuvant therapy, whatever we give, is better than doing nothing and going immediately to surgery.
No, I think that we have to move to that, but we have to prove that.
Okay.
But again, and paradoxally, the guidelines are now more and more incorporate this kind of statement, but without any proof.
And making then the statement, is it chemotherapy? Is it radiation? Is it chemoradiation? What do we need to advise to our audience? Or is it still an open question?
I think that chemotherapy probably should be initiated with high-risk patient or borderline, but of course we can classify borderline in different way. But initiate chemo, FOLFIRINOX or gemabraxane if unfit, and then reevaluate your patient every 2 months and go for surgery in the case of good response of stabilization, and add maybe radiation, but we have to do trial on that. And it's in preparation.
Mainly in the borderline resectable patients. That's mainly in the borderline resectable patients. I don't think we can, in my opinion, we can give a strong advice that in upfront resectable patients, the evidence is emerging, but the evidence is not yet there for preoperative treatment in resectable patients. I think guidelines should still say today that the evidence is there for surgery in this group of patients.
Yes, I agree, but the real prevalence or incidence of really resectable or fully resectable without any invasion of the portal vein is rare. When specialists in pancreatic radiology reassess the scanner, there is always, or nearly always, a contact of an invasion.
Okay. So the discussion is still open and studies are coming. There are 2 questions on biomarkers. One of the first question is, and I think it's a question of budget, doing NGS pancreas now systematically at diagnosis, ?
I think not systematically. I think that you have to push the evaluation of BRCA of HRD more and more with patient responding or stabilized under FOLFIRINOX or platinum based, but I think it's not to be recommended because with gene to be checked, it's not really clear.
Yeah. And then there is a question on HER2/neu. This might be a negative prognostic factor in pancreatic cancer. Is there a role for anti-HER2 therapy in pancreatic cancer?
Maybe, but it's very rare HER2 expression or amplification in this kind of. I think it's 2 or 3% of patients. But yes.
The last question is coming back to the discussion on neoadjuvant therapy. Mostly we are combining radiation with chemotherapy. Is there a place for newer targets like immune therapy in combination with radiation? Is there for the moment, based on the data, any evidence that immune therapy might play a role in pancreatic cancer?
Today, no. In combination with chemo or with radiation therapy, maybe. Previous data are not really convincing, but it's very difficult to assess what happened and what is the real benefit of doing that. Just using a checkpoint inhibitor, it's probably not the good way. We have to be more inventive and use more combination, focusing on maybe macrophage of fibroblasts of stroma, but it's extremely complicated, I think. A lot of new drugs.
So I've gone around the table. What do you want to do in pancreatic cancer? Which is a new drug that we have to find? Which is a new target?
Well, you can't answer for all pancreatic cancers.
Let's suppose neoadjuvant therapy.
No, I really don't know how to go. I think pancreas cancer is difficult because you can have molecular targets, but it's another tumor with stroma, with blood vessels. I think it's going to remain different from other tumors for me.
Eric, we tried everything.
There are different drugs. They are very early. Some of them preclinical, working on the stroma, and I think that's the way. There is a new class of agents that's now in phase 3, interfering with the metabolism. So that's a new direction. We don't know whether it's going to be successful, but at least a small phase 2 study in combination with chemo was led to quite impressive data. The phase 3 is finished now. We don't have yet any results. So there is something to come. And then a third point is novel immunotherapy combinations, just not PD antibody alone, but new combinations. And there are some in preclinical setting, and some of them, let's hope, will be active in pancreatic cancer.
Okay. Yvonne, last suggestion?
I think to re-emphasize the fact that we probably do not stage properly our tumors, and I completely agree with Jean-Luc. It is really often that we do stage patients as a borderline that was thought to be readily resectable, and probably that's why we more and more move to neoadjuvant. Although I agree, we have very low evidence.
Okay. Let's close.
We are getting thanks for all your nice talks here, so thank you. But you still had one last...
What we call in Flemish, een uitsmet.
One last question to tackle, right?
So recently everyone is screened for DPYD deficiency. What about the difference between the germline mutation and the somatic mutation? One patient in our hospital had discrepancy between pathology and genetic testing on serum. Karen.
Yeah, it's difficult to explain in 1 minute or the
but
whole...
you only have one minute.
But the whole idea... But basically, DPD testing is germline testing. You want to know whether you have one or two alleles that are attached by a certain genetic problem. Okay. Now I have to be fast. And somatic testing is testing on tumor material. So you don't go for your innate material. You basically don't take a piece of normal material to look for the two alleles of your genetic material. So I know the NGS people, the somatic testers, want to do this for a lot of pharmacoclinical genetic issues, but I don't think you can state that NGS replaces germline testing. And also, we don't want to have all this testing done in the big centers. Some people tell us that we want to draw this to universities, but we're also supporting a metabolic test that is very cheap and can be done everywhere. That's the rather short part.
Perfect.
But a very clear answer. Looking at the time, we went a little bit over time, which is great, I think, because it was all very interesting. Everything you said, the discussions, the questions that we got from you, ladies and gentlemen, thank you so much for participating in that. May I express warm words of thanks for all our speakers here in our studio, Professor Jean-Luc van Latem, Professor Karen Geboes, Professor Erik van Kutsen, Professor Ivan Borbat, and of course my wonderful chairman on my left side, Professor Mark Peters, thank you so much for being here. You, ladies and gentlemen, my deepest gratitude for staying with us this evening. I'm pretty sure that it has been as interesting for you as it has been here in our studio, and I would really like to see you again in one of our next e-meetings. For now, goodbye and good night.